rather than, well, since Sarah started recording, I might go ahead, get started. So it's my pleasure to introduce today's speaker, Dr. Umesh Venkatesan. Dr. Venkatesan came to us from the Mass Rehab Research Institute in Elkins Park, Pennsylvania, where he served as an institute scientist and director of the Brain Trauma and Behavioral Lab. He also has a faculty appointment, assistant professor of rehab medicine in Thomas Jefferson University in Pennsylvania. Dr. Venkatesan is a clinical neuropsychologist by training. He received his PhD in clinical psychology from the Penn State University, and also his postdoctoral fellowship focused on polytrauma and TBI rehab at the VA Boston Healthcare System. Dr. Venkatesan's clinical service and research centers around aging, dementia, and TBI. His primary focus is in moderate to severe TBI as a chronic disability, particularly in its intersection with aging and age-related medical complications. So his research is currently funded by MIH and NIDAR, MIDIR. He has authored more than 30 peer-reviewed journal articles and book chapters. His work has been recognized by multiple awards from local and national organizations over the years. So I'm very excited to have the opportunity to learn more about his research today. Without further ado, please join me and welcome Dr. Venkatesan. Welcome.
Thank you. Thank you for that lovely introduction. Just making sure, because I took myself off mute. Can you hear me?
Yeah, you sounds great.
Okay, great.
Yeah.
All right. So thank you for having me. It's a pleasure to give a talk. I have been to UAB once. I interviewed for internship there. I won't say the year, but I know of its great PM&R department. We work with some folks from there in the TBI model system. So it's a pleasure to give a talk to you all. All right. So a little bit about me, and the lovely introduction covered this, but as it was mentioned, I am a clinical psychologist and neuropsychologist by training. I did my undergraduate work at Johns Hopkins, then went to Penn State. I did a neuropsychology internship at Brown, and then finally ended up at the Boston VA for postdoc, where I was studying post 9/11 veterans, doing neuropsychology, but also doing trauma interviews with these veterans. And studying the effects of both on function, on mental health and disability. Since 2019, I have been at the Moss, now the Jefferson Moss Rehabilitation Research Institute. It's a mouthful, but we have to say the whole thing. And as part of that, I am assistant professor in rehab medicine at Sidney Kimmel Medical College. I think this is important given the type of topics I talk about to do identity disclosure. So I personally choose to do them. So I identify as a cisgender man. I'm the son of immigrants of South Asian heritage. I do not identify as having a disability. I grew up in the middle class and I was born and raised in New Jersey, probably the most important fact that you need to know about me. And there's little Yoda graphic. And I do not have any conflicts to discuss regarding this talk. So some of the objectives for today are to define quote unquote psychosocial pathways and their relation to social determinants, particularly related to TBI. Discuss the role of select psychosocial pathways in post-TBI health outcomes. And then finally, apply a life course approach to evaluating and managing post-traumatic brain injury. So what are psychosocial pathways? I'm sure many of you have heard this term, used this term in your work, but what are these pathways in this talk? What am I referring to? So psychosocial, as the name implies, both social and psychological factors, right? So it describes how social factors affect individual states of mind. Essentially, it's an individual by context interaction. And I like to think of these as including both exposures and responses. So it's a continuum that has both social exposures, which imply that they do something to people's mental states, and then you can also study them at the level of psychological responses that are socially informed, as I like to put it. So a few of these variables that we might study as part of psychosocial pathways are adversity, um, social support, self-efficacy, experiences as stigma. And you can see how these variables could be studied at sort of the exposure level of events or experiences people have had, and also the psychological response level. And I'm going to be talking about both sides of those today. Naturally, these arise from social determinants of health. So as most of you, if not all of you, are familiar with, social determinants of health are the conditions and the environments where people are born, live, learn, work, play, worship, et cetera, and they affect a wide range of health, functioning, and quality of life outcomes. So the psychosocial pathways essentially arise from these social determinants. Social determinants themselves say nothing about the mental states of people, the psychological states, how people interpret these social determinants. So an example of this pathway might be poor access to healthcare, which is a quintessential social determinant of health, right? Leads to perhaps reduced self-efficacy in some individuals, which might then lead to poor health outcome because of maladaptive health. And I like to show this figure as well. A lot of my colleagues who study social factors in TBI also really enjoy this Uri Bronfenbrenner's ecological systems model. And this is a fun little graphic about how people are embedded within their community, which is embedded within larger systems, institutional, structural. And when we talk about social determinants of health, I'm not sure if you could see my pointer here, but we're talking about the level of the individual and how they interact with their immediate environment, their community influences. So essentially, these little arrows here are what we're talking about when we talk about psychosocial pathways. And if you see in the center here, it says internal working model. Those of you who reach really back, if you took Psychology 101 and learned about attachment theory and John Bowlby, you'll remember the internal working model, which is listed here. It's how we sort of organize our thoughts about the world, form impressions, and how we use those thoughts and impressions to make judgments about the world and interpret the world. So that really is formed with these interactions with the immediate environment. That's what we refer to as psychosocial factors or pathways. And why are we interested, or why do I think we as, like I said, I'm a psychologist, behavioral health professional in rehabilitation. Why should I and people like me be interested in these psychosocial pathways beyond just descriptive, thought exercises? Well, like I said, social determinants of health, like the economic, social, and environmental influences, impact upon these psychosocial or these mental states, so enacted and lived experiences of people, and together they give rise for observed health disparities between populations, so between different racial subgroups, between different socioeconomic subgroups, and disability. So we know that those together affect disparities. But when we're talking about intervention, if we're just talking about social determinants of health, we are really talking about structural interventions. We're talking at the level of policy, at the level of institutions and communities that psychologists and other rehab professionals may have a hand in terms of helping to consult, design, inform, and also advocate. But we ourselves are not going to single-handedly construct these structural interventions. That requires a much more larger interdisciplinary effort. Where I think we can effect much more immediate, meaningful change is at these enacted and lived experiences, which are within the person at the individual level. So this is when we're talking about individual level interventions like coping and just living in an imperfect world and trying to optimize health outcomes given the circumstances. And so this is what motivates me to, and this figure is decidedly less fancy than the other one because I created it myself. So, but this gives you an idea of how I organize my thoughts and why I'm really interested at this level. So one psychosocial pathway and specifically psychosocial exposure that I've been really interested in the last 2 to 3 years when I first started this study is adverse childhood experiences. Again, a term that's probably not foreign to most of you. And I won't belabor what these mean, but they are potentially traumatic events, and that's really important to remember, that occur in childhood, so under the age of 18 years old. So, for example, experiencing violence, abuse, or neglect. They're traditionally referred to stressors within the household. Adverse childhood experiences increase the risk for mental health problems in adulthood. There is a whole corpus of literature about this, but also strong evidence that they impact independently upon physical health conditions like cardiovascular disease, diabetes, and perhaps even dementia as literature is emerging. I was specifically interested in this in traumatic brain injury, not only because there really hasn't been much work done, but also there is some evidence to show from retrospective studies that higher ACE exposure increases the risk of sustaining a later TBI, suggesting some sort of pathway of risk from early childhood adversity to the risk for actually having a brain injury. And one hypothesized pathway, although it hasn't really been investigated, is that at least for the initial incidence humps that we see in young adulthood for the increased risk of brain injury, ACEs may increase the likelihood of risky or aggressive behavior that results in brain injuries. So our goal in one study, in this initial study, intended to kind of be as a pilot, but ended up in more subjects, so I can't really call it a pilot, was to characterize adverse childhood experiences in individuals with brain injury and to really do a deep dive into this, provide a good characterization, and just start to look at how they affect post-traumatic brain injury outcomes as we traditionally define them, particularly mental health outcomes and behavioral outcomes. So this, I'm happy to, it has been presented. If you've seen me talk at different places, it has been presented before. The analyses have been sort of continuously refined, and I'm happy to say last week it came out, and it's fully published in Disability and Health Journal. So we used something called the Philadelphia ACEs survey in this study, and there's a lot of ACE questionnaires that are, the BERFIS has an ACE questionnaire too, but this one was designed specifically for the Philadelphia area to not only capture the conventional ACEs, like household level ACEs that I was mentioning, but also community level adverse childhood experiences like violence and discrimination, neighborhood safety, and things like that, which have been found in urbanized, highly urbanized areas to also be important for health, may have unique effects on health in these populations. And of course, given that we are in Philadelphia, a highly, highly urban environment, this was important to include. So we were very excited to have a sort of questionnaire that was appropriate for the sample. I have a little bit here on the sample. It comprised 85 individuals, and they were quite chronic on average, about a average of 11 years post-injury. We didn't have a great representation of non-Black or non-white individuals, but we did have a fair number of Black individuals. It's pretty typical of Philadelphia area recruitment. And just to quickly go through some of the highlights of the results, and again, you can check out the paper, but emotional abuse, physical abuse, and alcohol abuse in the household were each reported by 36.5, so over a third of the sample. A whopping 22.4, almost a quarter of the sample reported sexual abuse, and this wasn't just this was penetrative as well, a quarter of the sample. And witnessing community violence was the single most reported community and overall adverse childhood experience at almost half of the sample. So these were very striking numbers. We did look at the Philadelphia area data. We couldn't do direct statistical comparisons because that wouldn't be wholly appropriate, but we could see that these estimates, even though this was a small sample of TBI, was quite high even compare to the Philadelphia estimates that are already elevated. Um, and I want to show you this graphic. I know it might be a little bit overwhelming, but we are always interested in not just aggregate patterns of data, but also individual level patterns. So this is something called an upset plot. It's basically a Venn diagram for multiple categories. So what we did here is we took the ACEs that were most commonly reported by at least 20% of this sample. And we just sort of plotted them out to see different patterns, different combinations. And you can see here that there's no quite consistent pattern of adverse childhood experience reporting. Each individual is quite different. All these ones mean an individual person. So this person had this pattern, this person had, a second pattern that was all quite different, and we couldn't really tease apart a specific pattern of reporting. So people may have the same ACE score, but have sort of diverse experiences. And you can see here just the top 20%. This is what they reported from, like I said, community violence, but also down to sexual penetration, sexual violation were among the top reported ACEs in the sample. So this is really, it was just striking to us to see that, and then to see the heterogeneity in the reporting. We also looked preliminarily, of course, at demographic characteristics, clinical characteristics, how the total ACE score, we just add them all up, how that was associated with different characteristics. And we found that really, as far as clinical characteristics like injury severity, there were really no relationships there. In terms of demographics, only lower years of education was associated with greater community ACEs specifically. We were also able to statistically test between Blacks and whites. And we found that individuals who identified as Black did experience greater community ACEs. And also, we did look at current neighborhood socioeconomic status, thinking that perhaps if people were exposed to community ACEs early in life, that might predispose them to be in socially deprived to live in socially deprived neighborhoods throughout life, given the literature on ACEs and how it impacts upon later life. And indeed, we did find that current deprivation, where people live right now, was related to their level of community ACEs that they had in childhood. And just a quick note, this, for those of you who are familiar with the model system, this is very similar to the neighborhood socioeconomic index that we used there, and that was just published on. It is a principal component analysis of census tract data. So this is an objective measure of neighborhood deprivation. Interestingly, also, adverse childhood experiences contributed significantly and independently. So this is beyond age, sex, education, racial identity, injury, chronic time post-injury and severity, to both psychological symptom severity overall and health-related quality of life. Now, these are fairly small effects. They are for behavioral health research pretty typical, but I will note there that these R squares that contributed, they contributed just about almost as much as the variance contributed by demographics and clinical characteristics combined. So that was really interesting to us. So these exposures, like adverse childhood experiences, are definitely contributing to behavioral health outcomes after brain injury, as they are in the typical population as well. But we're also interested in psychological responses, as I mentioned, on the other end of the sort of psychosocial pathway. So we wanted to look at some of these responses, and what we've taken an interest in recently is experiences of stigma and a couple different forms of stigma that I'll discuss. So one form, now stigma includes things like stereotypes, prejudice, discrimination, all the things at the sort of cognitive level, emotional level, and also at the behavioral level. So two subtypes of stigma we have looked at are perceived discrimination. So this is perceived unfair treatment by the public due to one or more stigmatized identities. And we've also looked at internalized stigma, so the incorporation of publicly held prejudices and stereotypes into one's self-concept. And we've looked at these in separate studies that I'll continue to discuss. And we were interested in this because there is, again, data preliminarily in brain injury, mostly qualitative, that shows that stigma is an important concept in the lived experience of people with TBI. People with TBI oftentimes in support groups do cite stigma as a barrier, as a source of stress um, in their daily lives, and that interfere with their ability to function. But few quantitative studies exist, and they don't really map on well to the social psychological theories that we have. So we've been interested in this. So in one of our studies, this came from a parent study that was looking at aging with TBI, which was mentioned as another one of my interests. So this was an older sample. The average age was about 64, I believe. They were also quite chronic, about 10 years post-injury. And we looked at both major experience of discrimination and everyday experiences of discrimination. These are from popular scales that developed by Williams at Harvard. And major experiences of discrimination refer to things like being denied a bank loan, um, being denied housing, and things like that. And things that don't happen often every day, but really may impact life and impact life trajectories because of their consequences. And then everyday experiences of discrimination are sort of interpersonal slights and things that people experience on a day-to-day basis, being treated unfairly because they're perceived as a person with disability or due to another identity. And so they're more cumulative. Microaggressions may fall within this category. And we were interested in looking at these two different types of discrimination experiences and their impact on behavioral health outcomes. So we looked at several different outcomes: cognition, psychological symptoms, neurobehavioral symptoms, societal participation, and quality of life. I have there, I apologize for the acronyms. This table is pulled from the paper, but you can see there I've highlighted or bolded the significant relationships we found with correction. So essentially, there weren't relationships with objective cognition, but we did find relationships between both major experiences, MED, and everyday experiences, with just about every other health outcome from mental health to participation quality of life. And when we looked at this in regression models, controlling again, we want to make sure we're factoring in demographic and injury-related factors. Only the everyday experiences were predictive, continued to predict uniquely these outcomes, all of these outcomes actually. We did also want to see, because we asked people about lifetime discrimination here, if I didn't mention that in the past, and we wanted to look, and this questionnaire is structured such that it doesn't ask each question specifically about a type of discrimination due to a certain type of identity. Only after completing the everyday discrimination questionnaire do they ask, generally, what do you feel most discriminated for? Which identity? Why do you think people treat you fairly? And so we were able to look at that, and we did some sensitivity analyses that reveal that relationships were not driven by disability-related discrimination. So if we took out the folks that were attributing their everyday experience of discrimination predominantly to their disability, TBI-related disability, and we ran these again, we found many, if not all of the same relationships. I think only participation became marginal then. But we still found the correcting for the covariates, the same relationships. And I'm going to show you this graphic. Now, this is from another publication that used the same sample, just a slightly smaller version of the sample. But I just want you to look at these graphics and get an idea, because I think they are representative of the full sample. The sample sizes are small. This is because this is people who report to any sort of everyday experiences of discrimination. And on the left-hand side, you have people who identify as Black, and on the right-hand side, you have people who identify as white. And you can see here that expect in the Blacks, in individuals who are Black, almost half of them, or 40% of them, reported that despite having a TBI, their experience of discrimination were in large part due to their racial identity. And on the right side, there was much more white individuals who attributed their discrimination to TBI-related disability. A small percentage to race there, and we can talk about what that means. That's beyond the scope of this presentation probably, but we do give the questionnaire to both to all types of individuals, regardless of their racial identity. But this gives you an idea of that, and I'll mention also, we did not find differences at the aggregate total score level of everyday experiences between people who identify as white and people who identify as Black. But if you look at the within group level, there's definitely variability between the groups in what they attribute their discrimination to. I'll mention quickly too, we have not only looked at patient-reported outcomes like mental health and quality of life. We have also looked at physical health outcomes in some studies. So my colleague was interested in looking at cardiovascular risk factors, given that this is an older sample. This is the same, mean age of 64. And we did look at blood pressure measurements, and we found that major experiences of discrimination, but not everyday experiences this time, were significantly associated with higher pulse pressure, independent of race and hypertensive medication status. It was also independent of injury severity. There was also some evidence for a race by major experiences interaction on pulse pressure. So where we saw an association between the major experience of discrimination and pulse pressure, Black individuals, but not white individuals. So again, there seems to be some evidence of not only the independent contribution of experience of discrimination to behavioral health outcomes, but also to physical health outcomes. And the type of discrimination experiences related to either one might be different, but nonetheless, there are relationships that we can discern. I said that we also looked at internalized stigma in addition to perceived discrimination. And again, the internalized stigma refers to people adopting and accepting beliefs and attitudes and feelings that people in the world may have about disability and applying it to themselves and sort of taking on those stereotypes and incorporating those things into their self-concept. And that, of course, can result in detrimental outcomes. This hasn't been specifically studied in brain injury ever. It's usually either combined with questionnaires. Items are combined together with perceived discrimination, so it's hard to tease apart the different types of stigma, or it's just not looked at all. People just focus on discrimination. So we were really interested in this construct, specifically in TBI. So what we did was we took a questionnaire. It's called the internalized stigma of mental illness inventory, and we adapted it to TBI. And this has been done with the stigma bank and the TBI qual and the NeuroQual and things like that, just to change out the word mental illness and either put in disability or TBI there. And so from this larger measure of 29 items, we took certain subscales, and we had an internalized stigma measure, the ISME-9, which has been validated in other populations, and also a perceived discrimination subscale from there too. So again, perceived discrimination refers to this unfair treatment by society, but internalized stigma refers to stereotypes and prejudices that the individuals with disability are applying to themselves. And I don't have the data here, but the alphas for these were very good. They were all above, they were both above 0.8. Okay, so what we did with these measures, and I'll mention here, I didn't have the sample, but this is the same sample from the Adverse Childhood Experiences study. They completed a battery of things, and this was one of them. So this is again in about 85 people. And on the left-hand panel at the top, we just wanted to see the variability in internalized stigma. Is this zero inflated? Or is there a good distribution? We'll be able to see relationships with other measures using this particular measure of internalized stigma. And as you can see, we found a nice normal distribution of people sort of reporting anywhere from very little to quite a lot of internalized stigma. On the right-hand side are the actual residuals of when you regress internalized stigma on perceived discrimination scores. And so we didn't do this just to check our assumptions, as we should be doing for regression models, but we wanted to see if there were, how that distribution fell, because we wanted to see if we could separate out people who are sort of high internalizing and low internalizing. So based on their discrimination that they've experienced, do they internalize more stigma than that would be predicted or less stigma than that would be predicted? And are there defining characteristics in these groups? And we wanted to do that because there is this effect called the stigma paradox in social psychological literature, which says that some folks who who experience public stigma like discrimination tend to internalize that stigma, and some people actually don't and are actually empowered by it. And there may be characteristics that are different between the two sort of subgroups. And so, again, speaking to individual differences and heterogeneity within the population of how people interpret these public societal treatments. And indeed, because this was a preliminary study, we focused mostly on effect sizes. But when we took sort of the right tail and the left tail of the distribution of the figure on the right, these residuals, we did find that they differed in pretty important ways. And the largest effect sizes we found were for injury chronicity, for cognitive ability that we operationalized as processing speed from the WAIS, and mental health symptoms as well. So those who were, let me see if I can get this right, fewer years out of their injury were more prone to internalizing more than their discrimination experiences would suggest. Those who had poor cognitive ability were more prone to internalizing, and those who had poor or more severe mental health symptoms also seemed to show much greater levels of internalization compared to their perceived discrimination levels. And I'll say overall, perceived discrimination accounted for about half the variance in internalized stigma. But again, you can see there that there may be, this is sort of initial evidence that there may be differences characteristically between the tails of this population, tails of this distribution. We were also really interested in something called the why try effect. This is something that's been defined by Patrick Corrigan, who's a preeminent stigma researcher. And he's described this effect wherein internalized stigma hinders the attainment of life goals, of functional goals, by reducing self-efficacy. And that this may be a cycle, but once people internalize, they say, you know, well, this is who I am, this is what I believe about myself. It affects their self-concept, and they don't try, or they may avoid, and they don't engage or participate meaningfully in activities because their self-efficacy has been reduced. And so, although this was cross-sectional data, we did look at this theory-driven path model. And we used a self-efficacy questionnaire, a self-efficacy for managing TBI symptoms, a questionnaire developed by Keith Cicerone, for those who are familiar. And we looked to see if internalized disability stigma did impact upon societal participation through self-efficacy. And indeed, there were relationships between internalized disability stigma and both self-efficacy and societal participation, and evidence for a explanatory pathway with self-efficacy for self-management in the middle. So this is preliminary evidence of both sort of the stigma paradox and the why try effect that we have from the social psychological mental illness literature applied to brain injury. So we were quite encouraged by this. So with all that being said, I've covered psychosocial pathways. I've talked about exposures within these pathways and also psychological responses, how they may, though we didn't directly study them, but how they may relate to larger social determinants of health at the structural level. And what does this all tell us about the framework about TBI rehabilitation, how we should be approaching rehabilitation, these psychosocial factors, how we might design interventions to address these things? And really one theory that has popped out that has come to the fore in a lot of medical science and rehabilitation science is this life course approach to brain injury rehabilitation. And it's exactly how it sounds like. So it is a theory and its associated approaches. So it says that additive and interactive, socially patterned physical, environmental, and socioeconomic exposures, that's just a fancy way to say these sort of psychosocial interactions and factors, throughout the lifespan influence later health, even across generations, which is an interesting thing. There's a time component to this, and they contribute ultimately to health disparities. Essentially, what this says is that one period of life affects the next one, affects the next one, affects the next one, and you can have cumulative effects, you can have interactive effects, and health outcomes measured at one point may not be the same as measured at another point, influenced by all these social, physical, environmental, and other variables. And it's informed, life course theory actually has kind of sort of informed by two different perspectives, which is a developmental perspective and a structural perspective. So the developmental perspective focuses, from developmental psychology, focuses on these certain critical periods of development, and how the stressors during these critical periods have sort of these pronounced effects on health trajectories. And they're more important than having the stressors in non-critical periods. And then you have structural perspectives that say, these social identities and institutions enact certain stressors upon the individual that either privileges the individual or disadvantages the individual. So the life course theory sort of incorporates both of these perspectives, that early on you have these critical periods and stressors to these critical periods that can really throw off or put you on certain health trajectories. But then later on, you do have modifiers in terms of risk or resilience that's dependent on your social identity and social mobility. So the critical developmental periods, something like adverse childhood experiences, and then later on, social identities might be something like societal stigma. And both of these things together over the life course impact upon health outcomes. And so the interesting or the important thing here is that what we study as quote unquote TBI outcomes, for example, community integration, right, a very quintessential outcome, are often in fact life course outcomes. So traumatic brain injury is another life event in a series of life events. And so a lot of things have come before it, a lot of things will come after it. It is another event that needs to be studied in the context of a person's entire lived experience. So measured health outcomes could reflect cumulative or interactive factors, especially when we're talking about, we use things like the GAD or the PHQ, for depression, anxiety. I mean, these are the same mental health questionnaires we gave to any population, but you get as your primary care doctor, right? They're not specific to TBI. And so when we're asking people about that, that takes into account not only, any TBI related factors, but anything else that has been going on in the person's life for perhaps much longer than they've been living with the TBI. And failure to consider these chronic non-brain injury sources of health problems may result in setting inappropriate rehabilitation goals. You don't have an idea of who this person was before and the level they were functioning at. Alliance ruptures and poor rehabilitation engagement, and also then cascading problems due to poor initial rehabilitation care and uptake and maintenance. So how can life course theory and approaches, inform interventions? Well, one obvious way is at the provider level. And here, one related approach is the trauma-informed care approach, which many of you have probably heard of. It's essentially just a framework, and it has many different principles that are really targeted towards not re-traumatizing the patient, maximizing the agency of patient, empowering the patient, being collaborative, fostering trustworthiness. There are about 6 pillars that are outlined by SAMHSA that constitute trauma-informed care. And so this may include a trauma assessment, a pre-injury trauma and post-injury trauma assessment from the providers, and incorporating those things into psychosocial treatments for the individuals, but also interventions at the individual level or at the patient level. So they can help us identify ideal timing of interventions. Like I said, these critical periods for interventions might be especially important. When we're talking about something like internalized stigma, we know that develops in large part from societal stigma and public discrimination, and because people internalize those experiences. And so the earlier the better, probably, in terms of when that disability identity is being formed to intervene on something like that. They can identify treatment content and targets. Again, you may be dealing with someone who does have a major brain injury, but they may have had a lot of very significant life stressors before the injury. And so that we can't just sort of treat the brain injury. We do have to treat the entire person and take into account their life context before the injury. And then we can also consider how interventions effects may interact with an individual's environment and resources, and how these intervention effects evolve over time. We're always talking about transfer and transfer packages, and how people can maintain intervention gains, but we have to also realize that the effects of our intervention are continuously it's not about maintenance, but they're continuously interacting with social support systems and economic systems and other policies that may impact the intervention's effects, make the intervention's effects stronger or weaker over time. And so considering those when we design our studies and also select our outcomes. Okay, so some key points here that I just like you to walk away with are that psychosocial pathways are conduits through which social determinants of health engender health disparities. Both exposures and psychological responses have implications for behavioral and physical health after brain injury. A life course approach to brain injury outcome science may contribute simultaneously to the scientific understanding and rehabilitative care at both the provider and patient level, I just mentioned. And an important point, I think, here is that while policy interventions are necessary, absolutely necessary, we unfortunately don't have as much control over them as individual healthcare providers, but we do have control over are these psychosocial pathways. And so we can affect meaningful change in these pathways, working, like I said, in an imperfect world and an unfair world to optimize the lived experience of those with brain injury and with disability in general. And I hope I made good time because I think, yep, that's it. So I would just like to thank my mentors and collaborators. We have a team of research assistants who are just both past and present, who are wonderful. Funding for the work that I presented in this talk is from the Pennsylvania Department of Health, and also from a foundation grant from the Albert Einstein Society. And of course, I would love to also thank our participants, many of whom are drawn from our research databases, the model system, and the registry here. This is research that is not easy to take part in sometimes when we're especially talking about trauma. And the willingness of patients to do so has been quite remarkable. And I have found that they, in fact, want to talk about these things because they feel it's important. Who they were before is very important to who they are now. So, which is not surprising. So just a thank you to them. And with that, I think we can take questions.